If you break your arm,
Ugh.
the fix is incredibly straightforward, right? I mean, it's visible. It's totally structural.
Yeah, exactly.
You get an X-ray, you see the jagged white line, a doctor sets the bone, and, exactly the mechanics of how it will heal. But what happens when the injury isn't a bone, but a feeling?
That is exactly where our desire for a neat mechanical fix just hits a brick wall.
Right.
We naturally want to categorize a medical problem as simply, broken or not broken. But treating the human mind requires us to abandon that entirely.
We are looking at a mountain of clinical pharmacology data, just trying to figure out why treating depression or mania is, well, less like fixing a car and a lot more like trying to hack a biological supercomputer. We are going to explore how these extremely common medications actually work in your brain and the complex biological roadblocks doctors have to navigate to find the exact right chemical key for a patient's specific brain.
And I think the best place to start is by looking at how neurons actually communicate, adapt, and, frankly, misfire.
Yeah, lay out the groundwork for us.
So clinically, we define depression as intense feelings of sadness, hopelessness, and inability to experience pleasure, and severe disruptions to things like sleep and appetite.
Right, the core symptoms.
Exactly. And on the flip side, mania is the exact inverse. It's racing thoughts, extreme self-confidence, overenthusiasm, and dangerously impaired judgment.
It's like the pendulum swinging entirely the other way.
Yeah, precisely. And for decades, pharmacologists have been trying to pinpoint the exact biological driver behind those massive shifts in human behavior.
Okay, let's unpack this, because the classic explanation that, most of us have heard is the biogenic pumping theory.
Right, the old standard.
Yeah, it's the idea that depression is essentially just a deficiency of certain neurotransmitters, specifically monoamines like serotonin and norepinephrine, at key sites in the brain.
That's the one.
And following that logic, my brain is just a little low on serotonin. So is taking an antidepressant just like topping off a low tank of gas in your car? You pour the serotonin back in, the fuel gauge goes up to full, and you just drive away happy.
What's fascinating here is that clinical pharmacology completely shatters that simplistic gas tank view.
Really? So it's not a fuel issue?
Not at all. The fatal flaw in that theory is what we call the lag time mystery.
The lag time mystery.
Yeah. When a patient takes an antidepressant, that drug does exactly what it's supposed to do immediately. It blocks the reuptake of neurotransmitters, causing serotonin levels in the synaptic cleft, the space between neurons, to spike on day one.
Oh, wow. So the tank is full right away.
The tank is technically full within hours. But the therapeutic relief, the actual lifting of the depressive symptoms, that takes anywhere from 2 to 12 weeks to kick in.
Wait, right, which completely contradicts the gas tank theory.
Exactly.
If the serotonin is floating around in the brain on a Tuesday, why is the patient still profoundly depressed for the entire month of October?
Because the human brain is highly adaptive and it aggressively resists sudden chemical changes.
It doesn't like surprises.
No, it hates them. When a medication artificially floods those synaptic spaces with serotonin or norepinephrine, the brain actually panics. It interprets that flood as a dangerous overload of signal.
So what does it do?
It deploys presynaptic inhibitory receptors, which essentially act like emergency brakes to slow down the neuron's firing rate.
Wait, so the brain's immediate reaction to an antidepressant is to actively fight the medication?
Exactly. It slams on the brakes. But if a patient continues taking the medication every single day over a period of 2 to 4 weeks, the constant, unrelenting presence of the drug forces the brain to concede.
It gives up.
Sort of. It undergoes a physical structural change called downregulation. The brain literally decreases the density of those emergency brake receptors.
Oh.
Yeah, they pull back into the cell membrane like turtles retreating into their shells. It's not about the fluid level in the tank at all.
It's about forcing the brain's physical architecture to rewire itself.
Yes, to permit enhanced signaling. Only after that physical rewiring occurs do you see a change in the patient's mood.
If you are listening to this and you've ever wondered why your doctor told you to just give the medication a month to work, that downregulation is exactly why.
It takes time to build those new pathways.
Right. The drug isn't slow. Your brain's structural defense mechanism is just incredibly stubborn.
That's a great way to put it.
So if the goal is to force the brain to rewire those receptors safely, how do we target them? Because that brings us to the modern standard of care, selective serotonin reuptake inhibitors, or SSRIs.
Yeah, these are your famous agents like fluoxetine, citalopram, and sertraline. They largely replaced older drugs because, as the name implies, they are highly selective chemical tools,
Precise.
very precise. Fluoxetine, for example, has a selectivity for the serotonin transporter that is 300 to 3,000 times greater than its affinity for the norepinephrine transporter.
Wow, that is a huge difference.
It is. It scans the chaotic environment of the brain, finds exactly what it's looking for, and basically ignores the rest.
And pharmacologists have gotten incredibly precise with this. I was looking at the data on escitalopram. It's actually the pure S enantiomer of citalopram.
Yes, that is a brilliant piece of drug design.
Basically, for those wondering, chemical molecules often have a left-handed and right-handed version, like twins that mirror each other.
Right, enantiomers.
Yes, citalopram is just the pure left-handed twin. By isolating just the one shape that perfectly fits the brain's serotonin receptor lock, without the clunky right-handed twin getting in the way, it becomes a vastly more potent inhibitor.
Exactly, it's a much cleaner fit.
But here is where I get a little stuck. If these SSRIs are so brilliantly selective, like a chemical laser beam, why do they still come with a massive laundry list of side effects?
Well, that is the million-dollar question.
I'm looking at reports of intense nausea, vomiting, insomnia, and sexual dysfunction. If it's a laser beam, why the collateral damage?
Well, if we connect this to the bigger picture, you have to remember that serotonin isn't just a happy chemical localized to one emotional center in your head.
Right.
Serotonin receptors are distributed throughout your entire body. In fact, a massive percentage of your body's serotonin is located in your gastrointestinal tract.
Wait, really? In your stomach?
Yes, where it regulates peristalsis, which are the muscle contractions that push food through your digestive system.
Oh, I see. So the drug is highly selective for the type of receptor, but it cannot differentiate based on location.
Precisely.
So when you take a pill to increase serotonin in the brain, you are simultaneously flooding the gut with it, throwing the digestive system's pacing totally out of whack.
You are stimulating receptors that manage digestion, not just mood. And that is what causes the nausea and GI distress.
That makes so much sense.
And the complexity doesn't stop there. We also have to look at pharmacokinetics, how the body metabolizes and clears these drugs.
Right, processing them out.
Yeah. Fluoxetine has a staggering biological half-life of 50 hours, and it produces an active metabolite that lingers in the body for an average of 10 days.
10 days, meaning the drug is still heavily altering your brain chemistry over a week after you've stopped taking it.
Yes, and we have to factor in genetics, too. About 7% of the Caucasian population lacks a very specific liver enzyme called CYP2D6.
Which does what exactly?
Well, the liver is the body's chemical processing plant. Without that specific enzyme, the assembly line breaking down these SSRIs basically halts. These patients are what we call poor metabolizers.
Oh no, so the drug just builds up.
Exactly. It piles up in their system at dangerously fast rates.
Which means if you're a patient lacking that enzyme, a perfectly standard normal dose of fluoxetine might leave you feeling completely wired, sick, or just exhausted.
Yeah, it highlights why prescribing is never a simple math equation.
But wait, earlier we talked about how the brain physically removes its own receptors to adapt to the drug.
Right, downregulation.
If a patient just stops taking an SSRI cold turkey, their brain is now lacking both the drug and the receptors it destroyed, right?
Exactly, which triggers discontinuation syndrome. Because the brain is suddenly starved of serotonin signals, patients experience severe headaches, malaise, agitation, and extreme nervousness.
That sounds awful.
It is. Ironically, though, fluoxetine's massive 50-hour half-life makes it the least likely to cause this crash.
Oh, because it naturally and slowly tapers itself out of the blood over weeks?
Exactly, giving the brain time to readapt.
Okay, before we move off SSRIs entirely, we have to highlight a vital clinical warning from the source material. These specific drugs carry a serious risk for children and teenagers.
Yes, this is incredibly important.
Clinical data shows about a 1 in 50 risk of suicidal ideation when pediatric patients are treated with SSRIs. The developing brain reacts to these profound chemical shifts in highly unpredictable ways.
It does. It's a critical safety protocol, which is why any dosage change in a teenager requires intense monitoring.
Right. Now, SSRIs are powerful, but serotonin only handles part of the brain's emotional bandwidth.
That's right.
What happens when a patient is so depressed that their physical body actually aches? Serotonin alone isn't enough to address that, right?
No, it's not. Which forces doctors to bring a second chemical into the mix, and that is norepinephrine. This is the domain of the SNRIs, serotonin and norepinephrine reuptake inhibitors. like venlafaxine and duloxetine.
It's kind of a two birds, one stone approach, but how exactly does adding norepinephrine stop a physical backache?
It comes down to descending pain pathways in the central nervous system.
Okay.
So pain signals travel from your body up your spinal cord to your brain. But your brain also has pathways that travel down the spinal cord to modulate or dampen those signals.
Like a filter.
Yeah. And serotonin and norepinephrine act as the chemical gatekeepers in the spinal cord.
So they can literally close the gate on pain signals before they even reach the brain's awareness.
Precisely. SNRIs enhance both of those gatekeepers simultaneously. This is uniquely effective for depression accompanied by chronic physical symptoms.
Consider a 25-year-old patient who has severe depressive symptoms, but she's also dealing with debilitating muscle aches, and all her physical lab tests come back totally normal.
A very common scenario.
An SSRI might lift her mood, but it leaves the body pain entirely untouched. But an SNRI like duloxetine, it's the exact biological key for her specific lock.
It treats both.
Right, it treats the psychological despair while physically dampening the nerve pain in her spine.
Though we must note, duloxetine is extensively metabolized in the liver, so it is strictly contraindicated for anyone with hepatic insufficiency.
Good to know. But what if a patient simply cannot tolerate the collateral damage of these drugs?
Yeah, that happens a lot.
If an SSRI is ruining someone's quality of life because of severe sexual dysfunction, we need customized tools. And that is where the atypical antidepressants come in.
Atypicals are a fascinating mixed group of agents that hack entirely different sites in the brain. They aren't necessarily better at treating core depression than an SSRI, but their highly specific side effect profiles make them incredibly valuable for certain individuals.
Let's look at bupropion, widely known as Wellbutrin. Here's where it gets really interesting.
It is a unique drug.
It acts as a weak dopamine and norepinephrine reuptake inhibitor.
Yeah.
But what makes it a powerhouse is its dual utility. It doesn't just treat depression.
No, it actually attenuates the withdrawal cravings for people trying to quit smoking tobacco.
Which is amazing.
Oh.
And crucially, it completely bypasses the pathways that cause the sexual side effects seen with SSRIs.
But you do have to respect its specific risks. Bupropion lowers the seizure threshold, so it is absolutely off-limits for patients with seizure disorders or eating disorders like bulimia.
Right. And then there's mirtazapine, which blocks presynaptic alpha-2 receptors.
Another atypical.
The clinical data notes that it causes massive sedation due to antihistaminic activity and frequently triggers an increased appetite and severe weight gain.
Yes, those are very prominent effects.
Honestly, sedation and weight gain sound like a nightmare scenario for someone already struggling with depression. Why would a doctor ever intentionally prescribe a drug that does that?
Well, this raises an important question about how we define an adverse effect. You have to flip your perspective entirely.
Okay, how so?
Imagine a profoundly depressed patient who is suffering from severe anorexia and debilitating insomnia. They aren't sleeping, and they are losing dangerous amounts of body weight.
Oh, I see where this is going.
For that specific physiological state, sedation and weight gain are no longer side effects. They are highly desirable, life-saving therapeutic benefits.
Oh, wow. So we are literally matching the drug's collateral damage to the patient's exact physical deficits. If you have, say, a 55-year-old teacher who is deeply depressed, can't sleep, and is devastated by the sexual dysfunction caused by his previous SSRI, mirtazapine is the perfect customized intervention.
It is.
It treats the mood, knocks him out at night, helps him eat, and restores his sexual function.
Exactly. It's precision pharmacology.
But if we have all these precise, customizable modern tools, why are we still studying and occasionally prescribing the older drugs developed back in the mid-20th century?
You mean the TCAs and MAOIs?
Yeah, exactly. I'm talking about the tricyclic antidepressants, or TCAs, like impramine and amitriptyline.
Well, because there is a subset of patients who simply do not respond to the modern selective drugs. When the precise tools fail, you sometimes have to rely on older mechanisms, even if they come with significant, sometimes life-threatening risks.
And looking at the pharmacology of TCAs, it's like trying to water a single houseplant with a high-pressure fire hose.
That's a great analogy.
Sure, the plant gets water, but you also destroy the drywall and flood the entire living room. I mean, they block serotonin and norepinephrine, but they are incredibly unselective.
Highly unselective.
They also block muscarinic, histaminic, and alpha-adrenergic receptors all over the body.
Which causes severe collateral damage. Let's look at the muscarinic blockade.
Okay.
Muscarinic receptors are a core part of your parasympathetic nervous system, which controls your body's rest and digests moisture-producing functions.
Things like saliva and tears.
Right. When TCAs block those receptors, the moisture stops. Patients experience severe dry mouth, blurred vision, and urinary retention.
Yeka.
Furthermore, TCAs are highly lipophilic, meaning they love fat. They distribute widely into the body's fat tissues and readily penetrate the central nervous system, making their half-lives wildly variable.
The safety margin is terrifyingly thin. I mean, just 5 to 6 times the maximal daily dose of impramine can cause lethal cardiac arrhythmias.
Very dangerous.
You're giving a potentially suicidal patient a drug where a handful of pills is a fatal overdose.
Which is why they are rarely the first line of defense anymore, and prescriptions are heavily restricted in quantity. And, honestly, the same extreme caution applies to the other older class, the monoamine oxidase inhibitors, or MAOIs.
Right.
Monoamine oxidase is a vital mitochondrial enzyme found in nerves, the liver, and the gut. Inside a neuron, MAO functions as the cellular cleanup crew.
Sweeping up the excess.
Exactly. If excess neurotransmitter molecules leak out of their storage vesicles, MAO oxidatively deminates them. It basically destroys them to keep the neurons safe.
So if an MAOI drug like phenelzine intentionally deactivates that cellular cleanup crew, massive amounts of neurotransmitters accumulate and leak out into the synaptic space.
Yes.
It's a huge flood of chemical signal, which is highly effective for atypical depression. But if you nuke this enzyme, you trigger one of the most terrifying interactions in medicine, the cheese effect.
Yes, the infamous cheese effect. It is a classic, severe drug-food interaction.
I saw something in the notes about cheese and wine. How does a psychiatric medication turn a charcuterie board into a medical emergency?
It sounds absurd, but it's deadly serious. Many aged foods, aged cheeses, smoked fish, chicken liver, and red wine contain high levels of a substance called tyramine.
Okay.
Under normal circumstances, the MAO enzyme in your gut completely destroys tyramine before it can enter your bloodstream.
But if you are taking an MAOI, your gut's cleanup crew is disabled.
Exactly. The tyramine absorbs intact into your blood. Once it reaches your nerve terminals, tyramine acts like a chemical bomb, causing the massive release of stored catecholamines.
Oh, wow.
Your blood vessels constrict violently, triggering a sudden hypertensive crisis, which is a life-threatening spike in blood pressure.
Just from eating cheese.
Just from eating cheese. It causes stiff necks, tachycardia, nausea, and can easily lead to strokes or seizures.
Yeah.
Taking an MAOI means adhering to incredibly strict, unforgiving dietary restrictions.
That is wild. Now, everything we've covered so far, the receptor rewiring, the serotonin gut reactions, the tyramine bombs, it all deals with unipolar depression. But if we shift to the opposite pole, treating mania and bipolar disorder requires a completely different approach. And the undisputed gold standard here is lithium salts.
Yes, lithium is considered a true mood stabilizer, capable of managing both the depressive lows and the manic highs. It is remarkably effective, treating 60 to 80% of patients exhibiting mania.
But we need to pause here because this absolutely blows my mind.
What's that?
We are giving patients a literal heavy metal salt. It is incredibly toxic.
Oh, absolutely.
It has a razor-thin therapeutic index, meaning the difference between a helpful dose and a poisonous dose is minuscule.
Very true.
It causes hand tremors, extreme gastrointestinal distress, and polydipsia, which is an unquenchable extreme thirst because lithium competes with sodium in the kidneys.
Yes, patients have to drink a lot of water.
Doctors have to constantly draw the patient's blood to ensure they aren't slowly being poisoned. And yet, despite all of this, clinical pharmacology admits that its exact mode of action is still technically unknown.
That's right. We don't know for sure.
Yeah. So what does this all mean? How are we using a toxic metal as a cornerstone treatment when we don't fully know how it works?
It remains one of the great mysteries of modern neuropharmacology. We don't have absolute certainty, but we do have very strong theories.
Okay, lay them on me.
The prevailing clinical thought is that lithium interferes with the brain's cellular switchboard, a specific second messenger system called PIP2, or phosphatidylinositol bisphosphate.
Okay, what does PIP2 actually do?
When a neurotransmitter hits a receptor on the outside of a cell, PIP2 is the chemical messenger inside the cell that relays the signal to the nucleus.
Like a runner passing a baton.
Exactly. During a manic episode, these signaling pathways are firing out of control. Lithium appears to deplete the brain's supply of PIP2, effectively throttling those overactive pathways.
It cuts the wires on the cellular switchboard.
Yeah, that's a good way to look at it. But what is truly profound is that if you give lithium to a person with normal brain chemistry, it does absolutely nothing to their mood.
Wait, really? Nothing.
Nothing. It doesn't sedate you. It doesn't cause euphoria. It only exerts its stabilizing effect when the biological system is actively oscillating out of control.
It's incredible. Treating the mind is just a breathtakingly complex biological puzzle.
It really is.
From mapping out the exact shape of an acetalpram molecule to fit a receptor, to bypassing a patient's missing liver enzymes, to dampening descending pain pathways in the spinal cord with SNRIs, we aren't just fixing a broken bone. We are hacking the very architecture of human consciousness.
And if we connect all of this back to the very beginning of our discussion, it raises an entirely new question.
Oh.
We established earlier that the actual relief from depression only comes after weeks of the brain aggressively downregulating its own receptors to fight the medication. The brain fights the boost in serotonin.
Right, the lag time mystery.
Right. If our brains are biologically hardwired to hit the emergency brakes and shut down receptors the second we try to elevate our mood chemicals, well, it makes you wonder.
Or what?
What if evolution didn't design depression as a broken disease state? What if, biologically, depression is actually an evolutionary hibernation state, like a protective shutdown mechanism designed to keep us safe during periods of extreme stress?
Oh, wow.
If that's true, these drugs aren't curing a broken system. They are simply chemical catalysts, aggressively forcing your brain to wake up and slowly rebuild its own connections.
That completely reframes what a psychiatric medication actually is.
It really changes the perspective.
Think about that evolutionary hibernation the next time you consider how we treat the human mind. Thanks for joining us on this deep dive. Keep questioning, keep exploring the hidden mechanics of the world around you, and we'll see you next time.